I know she did throw out a couple questions. So I'm wondering if those are the ones she threw out. Do you know which ones she threw out?
She said she threw out the NGN question, which was the very last one, which was a patient that said like they're coming in with cellulitis. These are their labs and these are their vital signs. Based off of this, like what would be your nursing interventions? And it was like one of them was coordinate with provider antibiotics, coordinate with provider potassium replacement, and then you had to put essential, not indicated, non-essential, or contraindicated. And then there was a couple other options she threw that one out. I guess she said a lot of people did that, and she threw out a math question.
Okay. So yeah, maybe ask her about that module one then. Because I know St. Gil will let you like, well, I think she goes over in class. Martin will maybe go over like highly missed questions in class. But for Martin, you definitely just want to like go visit her during office hours or make an appointment to go like look at your test with her. And St. Gil, you can do the same. So you can kind of, and I feel like they're both pretty reasonable. Martin, if you find somewhere that you're like, hey, the test answer says this, but like ATI book says this, and you can show her, she will give you points for that and she'll fix it. San Gil, I feel like if you just kind of like, she'll do the same thing, but I feel like if you just ask her like, where was this information? She'll like show you where it's at. So maybe like she's pulling from somewhere else besides her slides, which is weird because she said she was just going to pull from her slides. But did you feel like there was stuff on there that wasn't from her slides? Okay. So ask her where she's pulling it from then. I know Martin, it's mostly from slides, but I tagged a couple pages in the HI book that I'll let you guys know that I saw questions that were really similar on the test. And for St. Gil's class, if she's using the same test, they might be similar questions.
And honestly, I mean, don't get me wrong, some of the stuff that you went over, like there was quite a few things that you went over and that we went over in class that were in there. Like the IV hues and stuff and the blood, like which one, O negative, universal versus, recipient versus donor. And there was a lot of things on there. So there were like, it does help that you go over them because you do kind of hit a lot of the points that we end up getting asked. But there was just a couple that I was like, what the heck?
I remember one where it was a question about like what would be a congruent lab that you would expect with a patient with hyperphosphatemia.
And it's calcium.
The calcium is what I went with, but it was calcium level of 2.3. And it's like, we didn't learn calcium levels.
I only saw one calcium.
And I called her over and was like, and I showed her my like board, and I was like, I understand that like calcium and phosphate have an inverse relationship. So if we are hyperkalemic, we're going to have low calcium. However, you giving me a calcium level of 3.2 when I don't know what's normal because we didn't talk about that electrolyte.
Yeah.
I don't know how to apply that information. Yeah. She goes, oh, well, it was listed on the electrolyte document in Canvas. And I was like, yeah, but we didn't go over that. So like, no offense, but I'm like, no, nice try.
I think that's probably where we were thrown off then, because I didn't even look at anything on Canvas.
I don't know what to say. Sorry.
Because everywhere across the board where it was like, even she told us when we were in class, like your slides are your lecture. I mean, your slides are your notes. Like your slides are what you study with.
Yeah. So I was like, what do you want me to do with this? And I happened to have had calcium selected, and she sort of was like, you're on the right track. Like, don't change it. Because I also was like, what are you trying to ask me?
But also she told us a lot of stuff to know that we didn't have to know.
Oh, really?
Yeah.
Like pretty much everything we highlighted, half of it, like we didn't need to know that.
None of it she tested on.
Half of it definitely was in the test, like word for word, half of it was in the test. And then the other half, I was like,
but it was the half that she told us not to highlight.
15 to 30 minutes, but that wasn't even in there.
I wasn't even on there. That the other class had a lot longer to take their test than we did. So I'm going to bring that up tomorrow.
Yeah, you should. Did she give you select all or not? Did she give you partial credit on select all that apply?
Okay, which I think is what saved me, to be honest.
Same, me too. Honestly, I don't know if I'll offer that, but thank you guys, because that's what saved me.
Oh,
There was a lot
we
of
haven't even
questions though
talked
that
about it.
apply. Too many.
Yes, there will be. So there will be lots of select all that apply. But you do get partial credit, which will save you.
Even
And
third semester we get partial credit, or at least for you, I guess. Okay.
so I don't, because Harding's class, so it depends on who you guys have. Right now, there's only one third semester professor. And the reason she doesn't do partial credit is because she does her testing on ATI, and ATI doesn't allow partial credit. Like there's no option for it, which is dumb. I feel like she should move it to Canvas then, because even NCLEX does partial credit. So I have no hope for an A this semester, and that's fine. It's what it is. It's fine.
Well, that's what I
So-
was telling some people today. I was like, you know what? I'm a straight B student and I'm okay with that as long as I pass.
It's fine.
I think I just didn't spend enough time on blood, to be honest. I was okay for the most part with everything else, but when it came to blood products and stuff, I didn't spend enough time on it, and that's my own fault. But
Yeah.
Okay. And it's hard because like I'm sure that they don't keep the exact same test. I'm sure some of the questions are the same, because there were some that so a couple people said, oh, that's the same question you said like was on there. So there was like a few that I think are the same, but you know, they could change part of their questions. And so there are some things that I'm like, I remember this, and then it's like it might not be on there at all. So I don't know. It's just I'm like I mean, I can tell you what to focus on based on what was on ours, but that was the same that our pal for last semester, for when I was in second, he did the same thing. He'd be like, make sure you know this, because there's like 3 questions on it, and then there was like no questions on it. We're like, seriously? But I mean,
Which
they
kudos to
change
you
their
for
test.
remembering, because when I walked out of there and I was like trying to remember the questions, I couldn't remember a single one. I was like, I don't know how she remembers a whole semester later.
Well, it's usually when I go back and study and I look at someone, I'm like, oh yeah, there was a question about that. Okay, so before we get started, I just wanted to tell you guys in the these ATI books, the purple one, if you look, and it's on page 657, that's where it starts like post-op and pre-op stuff, like the peri-op that you guys are learning about. I felt like, so I think that one is actually anesthesia. But that whole section, so there's anesthesia, and then right after it is pre-op, and then right after that is peri-op or post-op. So like those last few chapters in there, so it's like chapter 94 all the way to like, I think it's just like the end, through chapter 96. I felt like there was a lot of questions that I was looking at in the back that I was like, these are very similar test questions. They're not exactly the same, because some of them have stuff that like you haven't learned or you're not going to learn yet. But a lot of them I was like, oh my gosh, I remember a very similar question, and a couple of the like the select all that applied, like the same answers were there, or like it really, really similar. So I think if you go through like and I feel like these like they kind of just give little like bullet points, you know, and I felt like because I was just reading through it barely like before I got on, and I felt like a lot of it I was like, okay, this is hitting really good bullet points, like, you know, so like not that you should be reading the whole chapter or anything, because I wouldn't ever do that, but I think they give really good bullet points for like what you need to know. And then like I said, just go over those questions and make sure like you're not memorizing the questions, but you're understanding like the critical thinking behind it. So that way, if you see a similar question, you're like, oh yeah, like I saw something similar on ATI, this is what they're looking for. One thing I do, and again, this could not be on it for you guys, but I remember that for Martin's class on the test, she had a question about like the JP drain or the hemovac drain that I was like, this isn't even really in the slide. Like it's barely mentioned. But she like asked a specific question about it. So I do feel like even though I say study from the slides, like what I mean from that is don't just like memorize the slides. Like if you see like it just says hemovac drain, it doesn't say anything else, figure out what a hemovac drain is, like what it does, what you need to look for it. So like go into detail on that, what they have listed. Does that make sense what I'm saying? And so, I mean, that's kind of what I try to do when I give you guys like my notes, and that's how I like study when I note take for these classes. So like when they talk about pain meds, they talk about like, and it says NSAIDs, opioids, acetaminophen, antidepressants, anticonvulsants. but that's it. It doesn't give any other information on it. And so what you want to do is you want to go, okay, well, NSAIDs, like what are the side effects of that? What do I need to know about NSAIDs, like opioids? What are the side effects? Like those kind of things, right? So make sure you're not just like memorizing the slides like that you're actually going through and understanding like behind thinking, like critical thinking behind that. So and then for Martin's quiz next week, definitely make sure you know, well, I'm gonna say definitely because this was ours, but it might not be the same, but 6 Ps. So the pallor, pain, polycothermia, how you pronounce that. Okay, so those 6 things. And then she will probably ask, I feel like on all of her quizzes or most of them, she has age-related changes. But when you guys did GERI, it was so general, like there's not specific age-related changes. But she might, hey, voice down, okay. She might ask, thinking in the background, I think. She might ask, like, what are like name 2 or 3 age-related changes in a GERI patient. So just make sure that you can just list a couple. And okay, and then as we go through, if there's anything that I'm like, oh yeah, this was like, you know, on the quiz. Okay, oops. Let me share this with you. So I just had like a little quiz that we can like, or just like a couple questions to start with, and then we'll go through those slides. Okay, so this one says, hold on, let me move this. Name 3 age-related problems that elderly adults face. So start spitting out some things. What are some age-related problems?
Slow wound healing.
What do you say?
Slow wound healing.
Oh yeah, good.
Decreased metabolism.
Okay, good. Gait.
Vision changes.
Good.
Decreased kidney function.
Good. Okay. Make sure that like on the test or quiz, they're going to be looking for more specific. So like decreased number of pacemaker cells, decreased chest wall compliance, like things like that, decreased cough reflex. Okay. So like you're getting like the good generals, but make sure that you know, and I think for this one, like if you just have a couple on the top of your head, that'll be good. I don't think you'll need like all of them. I will send you a list of all of them from the book so that you can kind of go through them. But there won't be, I don't think there will be a question that's like, well, there could be a select all that apply question. I kind of doubt it. But I would just, as long as you know, like almost everything's decreased, there's only a few things that are increased. Like it's like increase semantic memory. So that means like your intelligence doesn't decrease as you get older, right? Like, thank goodness. So your intelligence remains the same. But you might have like slower ability to recall random numbers. Okay. Okay. And then what are the 3 major causes of injury in the elderly?
Falls. MVA.
Fire.
Good. Falls, MVAs, and fires. Okay. So we'll go through the slides. Okay. Oh, and I'm going to put this in the chat so that you guys can just type your name in there. All right. So I feel like both of these lectures we will probably go through pretty quickly. So I would say the one mistake I made with this test, I don't remember what I got on this. It wasn't like a bad grade, but I felt like as I was like studying and going through it, I was like, oh, this is like easy, like duh. And like I didn't really put the like effort into studying. And so then I felt like when it came to the test, I was kind of like they're asking questions. I was like, oh shoot. So I would just make sure like you don't have to worry about baby boomer. You could cross that out. You don't need to worry about that. I mean, maybe just know it starts at 65. So right here, so see tables throughout chapter 6 for physical changes in adult years. I didn't really pay attention to that. So chapter 6, I actually just read it because we're doing GERI for my class right now, and it's like a really, really short chapter. So you could actually read it in probably like 45 minutes or less. Like it was so short. So it might behoove you to like just go through it and just scan it. I did for my class start writing down all of the age-related changes. So I'll send you that so it's all in one like document if you think that's easier for you. And then I would suggest, and like I said, like you don't have to like have every single one of them memorized, but just kind of look over them that you could recall them pretty easily. So like you would know like, oh, this is all decreased, but I know semantic memory is increased. Or like if you had to list like 2 or 3, you could list 2 or 3. Okay. Yeah, like pretty much everything is decreased, but you have increased bone loss, which makes sense, right? And increased subcutaneous fat. So most of them I feel like kind of make sense. Okay, but yeah, chapter 6 is like really pretty short. Okay, so most older adults have 1 or more chronic health problems. So I would know that these are chronic health problems that you're gonna see in them. And then risk factors are pretty obvious. Okay, so I can't remember if this is on the test or not. I mean, that's pretty easy to memorize. There was a question for me about hip fractures and I can't remember I'm trying to remember what it was. But I would just know that the problem with falls is that it's going to result in hip fractures. And then that's going to be long-term disability. So it's not a short-term disability. I feel like that was the question. It has something to do with disability. I can't remember exactly. If I think of it, I'll let you guys know. I would definitely know these pharmacologic effects. So understand like what's happening with the toxicity of the medication. So if your kidneys and liver filter everything out, right? And so if your kidneys aren't working as well because you have like less, your like GFR is slower and like you have less, I can't remember what the word is, like renal. I can't remember what it was. I just read it in the book, but anyway, you have less of these things working. I think you even have less like hepatocytes in your liver. And so that means that the medication is going to stay longer in your system, right? So that means the toxicity is going to go up. So normally if you're giving a patient something like every like 4 hours, you kind of need to be double checking with the older adult, like, well, what are their labs looking like before I give them another dose? Because maybe they're already at their therapeutic dose and we don't want to overdose them with anything. So with some medications, we're going to be doing therapeutic level testing just to make sure that they're at the right level they need to be. Let's see. And then again, the liver with the drug metabolism. So I feel like there was a question that was talking about safety in the older adults and talking about like just know that, you know, you're always going to make sure that there's no free, like, what are those rugs called? Like those rugs you throw on the ground, right? Throw rugs, rugs you throw on the ground, throw rugs. Those, they make sure that, you know, we're not having those in the house, that the halls are well lit, that they have grab bars in the showers, that there's non-slip mats in the shower. So those kind of things. So if there's like a select all that apply question, but they're going to word it in a way that you're going to be like, it's not going to be so obvious, right? So just make sure that you understand how you would keep an older adult safe. I don't remember anything specifically from this, but I mean, this is pretty self-explanatory. That's what I think that is hard about this is like, you look at it like, it's pretty self-explanatory. So it's trying to come up with ideas of like what they would ask about it. I do feel like, at least for ours, there was more testing on, like there's definitely some GERI in there, but there was more on like preoperative, like all that. And then what's the other section you guys are learning next week? Oh, the leadership. Oh yeah, there was some on that too. Okay, so they need increased rest. And so we're gonna have them not take naps during the day, right? Because a lot of times they have problems, like they have to get up at night because they have to go to the bathroom, which puts them at risk for falls. And then also like they can have insomnia at night. And so we're going to make sure that they are getting enough rest at night by not putting them at naps during the day. And a lot of this will sound pretty familiar from first semester. I feel like a lot of it is pretty like similar when they talk about GERI. I feel like there was just a general question that was like, when the nurse is caring for an elderly patient, what are some like cues she should be looking for or assessing for, like something like that. And so just make sure you know like what the older adult's going to need. So they're going to need a need for increased rest. They're going to need like, can they drive safely? Can they do they need hearing aids? Can they hear properly? Do they need walking aids at home? So just like, what would you assess for when talking to an older adult as a nurse? Okay, I think we just talked about this. Avoid caffeine stimulants. Maintain a regular bedtime schedule for them. So if we're creating an environment for sleep where it's like it's cool, lights are out, we don't have like a TV in the background, and we're doing like a regular bedtime routine, that's going to help them get to sleep. Okay, so Sangil specifically said to memorize this. I don't remember. I feel like I memorized this and it wasn't on the test for Martin. I don't want to say that and then you guys don't, and then you're like, it was on the test. So it could be. I thought it would be. To me, it seemed like a great select all that apply question, and it wasn't on ours. But Sangil did say to memorize this. So I think it would be good just to know kind of what these are. And like that it's still important to older adults, intimacy, right? Make sure you know STI rate in elderly is going up, so we need to educate them on safe sex. And we just talked about this, the accident prevention with these type of things. Influenza and pneumonia shots, we're going to make sure they're getting those. Any sort of boosters that they need, like especially like the shingles zoster, they need to get those as well. They should be getting an annual physical. Okay, so for these ones, make sure you know foods, and I listed some in here and I'll send you my slides. Make sure you know foods that are that have some of these things in them. I know that Martin loves to ask questions like about diet, because I know that I don't know. I think that she knows that we don't really pay attention to that. We're like, okay, foods high in fiber, but like, yeah, what are those though? What is high in fiber? And so I think she likes to ask questions like that. So like, you could memorize this, but then did you actually study to the point that you're like, okay, well, what is that? So I feel like on a lot of her tests, she has questions that's like, this patient, you know, needs a diet, you know, high in fiber, low in potassium, or whatever. And you have to know like what foods you'd be able to feed that patient. So I put a bunch of these on here. So I don't want to confuse you, but I trust that you're all smart, that when I say opposite of this, you know, we're looking for low fat foods, but it's easier, I think, to look at the high fat foods so you would know what not to give your patient, because there's a ton of options for low fat foods. So if you see, so like a lot of these things we think, oh, this is healthy. Like, yeah, walnuts are healthy, avocados are healthy. But if you have a patient on a low fat diet, you don't want to give them these foods. Okay. So don't get confused in thinking this is what we want to give someone with a low fat diet. Okay. That's why I said opposite. So these are foods we don't want to give. There was a question, it might not have been this test, but there is a question that talked about that you're feeding a patient something and like bacon was on there. So like, know that bacon has salt and bacon is high in fat. And I can't remember if it was a low sodium patient or what.
We had a
Was
question.
it today?
Yeah, it was like you have a food tray and you're gonna give which ones are these would be low sodium.
Patient has hypernatremia. What would you not let him eat for breakfast?
Yeah.
Okay.
It was like cottage
Tomato
cheese,
juice,
tomato juice,
bacon, eggs, leafy greens. What was the other one?
cottage cheese.
Cottage cheese.
Okay. So did you get it right?
I'm assuming I got it right.
I did. We don't know.
I don't know.
Okay.
I forgot eggs. I didn't put eggs because I was like, that's high in cholesterol, not high in salt, depending on how you make them, you know?
Eggs.
So I didn't put eggs.
Professor Gabby told us the answers were cottage cheese, bacon, and tomato juice.
Cottage
Bacon and
cheese.
tomato.
Yeah, cottage
does
cheese,
cottage
bacon,
cheese-
tomato juice. Because it is salty. Cottage cheese has
It's-
a lot of sodium in it.
It's a processed food.
Unsubscribe. That is malarkey.
And I almost clicked cottage cheese, but I was like, I don't know enough about cottage cheese, so I just left
no,
bacon
that's
and tomato
ridiculous.
juice.
No, pull over the car.
High
No.
in protein and low in fat, but high in sodium.
A la Ted
Yeah.
said, I reject that. Absolutely not.
Well,
Ridiculous.
that was one of the only ones I got correct.
Oh,
I'll,
that's funny.
I'll agree with tomato juice and I'll agree with bacon.
Bacon.
Cottage cheese can suck a D. That's ridiculous. Get out of here.
Let's look up cottage cheese to make Joey feel better.
I love
It-
cottage.
Yeah. How much sodium is in cottage cheese, please?
Hold on, let me ask Siri.
I don't know. Yeah, go find out. It's probably a lot because it's processed. I'm sure it's high in sodium.
It is a lot.
How is it? You guys, it's just
I
cheese.
bet that's what makes it all like curdled though.
919 milligrams in 1 cup.
That's a lot.
Probably why I love it and why I'm so thirsty.
It's it's 34% of your daily value.
Jesus Christ.
Well,
You can't fight it no
follow
more,
up on
Joey.
to follow up on that was not on any slide she gave us.
That is true.
She
What?
maybe she said she didn't even give us foods that are
Foods
high
for
in sodium.
sodium.
But I
You
gave them
told
to you
us,
guys.
but
Yeah.
not cottage cheese.
Well, I can't give you all the answers.
You
You have
said
to do some studying.
I didn't know cottage cheese was
I
highly
said processed foods.
I
said
I
remember-
did say processed foods, but I honestly didn't think cottage cheese. Well, I don't eat cottage cheese, so I don't know anything about cottage cheese. So I was like trying to break it down in my head, and I literally talked to myself the whole exam. You were sitting next to me. I don't know if you heard me, Lauren. I was like, she's gonna think I'm crazy, but I was legit like talking myself through every problem. And cottage cheese, I was like, what is cottage cheese? Like, have I ever tasted it? Is it salty? Would cheese have salt? And then I was like, yeah, but I don't know how much. So then I was like, you know what? Safe bet, don't choose it.
I didn't think cheese had salt.
That's
Whatever.
funny.
Whatever. Cottage cheese is
So-
bomb. Anyway, moving on.
Yeah. So for sodium, like anything that's processed, and so anything processed is going to be anything that's like not naturally you're getting from like the earth, right? So if it's going through a processing plant,
So no
So-
cheese is natural?
So we don't just milk cottage cheese out of the cow.
I'm
talking
pretty
about?
sure no. So
Unbelievable.
yeah, to make cheese,
Yeah.
you add salt when you make it, right?
Mhm. Yes.
I don't know, Lauren.
So
I
I-
never make cheese.
Same.
Well,
I was
even
like,
butter
I've
has salt in
never.
it.
I just eat
right?
it.
I know if you eat too much, it'll shut down your digestive system. It'll bind you up.
I think that cheese
that.
does too. I think that
Even-
you
Yeah.
Oh, not that much. 174. That's better than I thought.
But
But it
see, even
has a-
like the eggs. Oh, so the eggs wasn't a correct answer, correct? Wasn't one
Right.
correct
There's
answer?
no unless you
Okay.
put like salt in
Salt.
your eggs.
Right.
Eggs
Okay.
eggs would be fine. So yeah, so I would for sure where am I going? The stupid thing gets in the way. There we go.
Thanks, Adam.
So that's why I'm saying no. Like, make sure you have a broad idea of like what. So I feel like there's a question about fiber and know that apples have fiber. Like I know that was a question last semester because I got lucky and happened to like look at foods that had it and saw apples and I thought, oh, that's weird. I didn't know apples have fiber. And then it was on the test. So like know that apples have fiber. I don't remember if it's this test or one coming up, but I know in Martin's class there was one that was like patient high in fiber, so apples have fiber. Okay.
You
So
said
pretty
all
much
of these are high
anytime
in
we're
fiber.
talking about anything of foods, just search them to be safe.
Yeah, and I try to put them in the slides for you guys. And like I said, this isn't all encompassing, right? Like, yeah, there could be others. Like, I don't know. I don't think, cottage cheese. Here we go. Here's cottage cheese, but high in calcium, but also high in salt. So the one thing that you're going to have to look at though is think about, okay, older adult needs foods high in calcium, but low in sodium. So you wouldn't want to give them cottage cheese. So what else is high in calcium, but low in sodium? Well, probably milk, right? When we found out cheese. So kind of just think about that. Almonds are great, but they're also high in fat. So, but I don't feel like they're going to trick you like that. They're not going to put something that's like, yeah, well, it's high in this, but low in that, like it's going to be pretty straightforward. Like what's something high in fiber? They're not going to say this adult is low sodium, high fiber, blah, blah, blah. Because really, that's not really our job. That's the dietitian's job, right? And so the dietitian is going to be evaluating and then sending the like putting it in the Cerner, like this person's on a heart healthy diet or whatever, and then the cafeteria sends up according to that, right? So really, we're not doing that much with that, but I guess it's more with education. Like if we're telling a patient, like, hey, make sure there's foods, you're doing foods low in sodium. Like if we don't know what foods low in sodium are, then they're definitely not, right? So it's more, I think, for education that we're explaining to them what foods are.
As of today, I have a newfound love and appreciation for the people that work in the hospital cafeterias and are making the trays, because I could not have that job. I would feed everybody the same thing.
Yeah, I'm sure they have a list of like, this is like, these are approved for, heart healthy. Here's you can give them for heart healthy, whatever the other, I don't remember what the other ones are. I feel like everyone's on a heart healthy diet. Okay. So I did throw those in for you. So just keep an eye on them. Because there will probably be a question like that. Okay, so that's funny that Sangil had that same question, because that was definitely Gabby's question. Or Gabi's question. So I guess they are using the exact same test. Okay, and then yeah, the dental checkups, that's just because when you have dental health problems, that can lead to neuro and cardio problems, or infectious, which leads to sepsis. And then they can do daily exercise. So I feel like that was a question also. We need to remember, as nurses and also for the test, that adults aren't ever at an age where we're like, they're too old to have a healthy lifestyle. So like my grandma is like 91, and she like goes for walks every morning. And she's one of the very few, she literally has no chronic health problems. Like there's nothing wrong with her. It's insane. She's going to live to be 1,000, I swear. But like she can get up and go walking every day, and she eats a fairly healthy diet. So just because they're in their 90s or 80s or whatever, they can still live a healthy lifestyle and it will still benefit them, right? So we want to make sure that we're remembering that. Okay, let's scroll past all these. Oh, what happened? Okay. I think we kind of talked about this. The big thing with these is that this puts the patient all at risk for falls. And so we're going to offer everything we can. Like, can we give them a hearing aid? Can we give them a walker? Do they need glasses? And Medicaid covers, or Medicare covers a lot of these things. Okay. And that's just putting yourself in their shoes. I don't think you need to worry about this page. I feel like that's more like just FYI. Okay. So now let's go on to perioperative. Were there any questions about that one?
I feel like that one's the hardest, because I feel like it's so straightforward, but then when it comes to the test, I'm like, is it going to be so straightforward?
I feel like it was a lot of they're not going to ask you, well, I feel like there might have been a question of select all that apply, that like what kind of diet does the elderly adult need? And so you would do low fat, low sodium, high potassium, high cal, whatever. But I feel like a lot of it for the elderly patient is just going to be scenarios, right? So you have an elderly patient who lives like, you're a home health nurse and they live alone. What are your concerns, priority concerns when you walk into the house? Okay. And so I think just understanding what your concerns would be with elderly adults, okay, well, they live alone, which means they're taking medications by themselves. Can they see well enough to see the medication? Can they get the medication open? How's their mobility with being able to get to the kitchen to make food and get to the bathroom? Those kind of things, right? So you need to kind of think more than just like a basic list, right? So be able to really critically think about what are you looking for with an elderly patient. Okay. All right. Okay, so I know with this one, with Professor Martin's class, there was definitely a question that was which tasks would be performed in post-operative care or something like that. And in the PACU, which is post-operative, I don't know what that stands for. Does anyone know what that stands for?
Post anesthesia.
Thank you. Care unit? Okay.
Yeah.
Something like that. Okay. So she used the term PACU, and it was something like, I can't remember if it was select all that apply or you just choose one. So I do think it's important that you know when they have these phases up here, make sure you pay attention what's in each phase. And then she listed something that I was like, I didn't even know what that was. And I selected it and it was wrong because she's like, no, that's something the surgeon does, which, oh, debridement. Okay, that's what it was. And so I don't come from a health background. I taught elementary school, like first graders, which is why sometimes I have these stupid ideas of like how to like show you guys stuff. But I had no idea. Like I knew what debridement was, but I didn't realize it was a surgical procedure. And so it was like, what is performed? Could the nurse perform in the PACU? And I was like, yeah, debridement, sure. Like I thought it was just like they're just kind of scraping the wound. She's like, no, that's the surgeon's job. I was like, oh, sorry, I didn't know. So, and she didn't go over it in class. So.
We did learn in first semester that nurses do perform debridement. Like
Okay,
that was
that's what I
definitely
thought.
covered.
Well, it's the wound
that's not
debridement, but the
that's not
packing,
surgery,
but
though.
it's by packing. So you're not surgery, you're like packing it so that when you take it out, it debrides the wound.
Yeah, so like it's like wet to dry dressing. When you stick the
Okay.
like it in there and you pull it out, it's debriding a little bit. But like if you're actually gonna be like cutting off like white skin or like black skin that's necrotic or something, that's a surgical debridement.
So you guys are way smarter than me. So just know that.
They also didn't tell us if that only applied to med surg or because if you're in the PACU, that means that they obviously just recently had surgery. And they also told us that the surgeons are the first people to look at the incision or wound after surgery anyway. And that like we were never to crack it open. So it's like maybe that's what she meant. Like if there was debris done, then it would be the surgeon in that unit. But then once the surgeon clears them to move to med surg, it's over to the nurse to do it in med surg.
Okay. Yeah, I could see that because that definitely she does hit on that too, is that it's always like the surgeon doing the first one, unless for some reason he tells you differently, but it's going to be the surgeon. And then obviously you can do later dressing changes. But there was, it was something like that. And it was debridement. And I was just like, I don't know. And so, and I don't think it was select all that apply. I think I just got it wrong. So it's not debridement. If that's on your, I want to know later if that was on your test because I don't want you guys to miss that one. But and I can't remember what the right answer was, but anyway, just make sure that you know like what goes in each phase. Okay. So for pre-op, and I wish before they gave you this test that you actually got your OR rotations because like I took this test and then I did my OR rotation towards the end of the semester and I felt like then it like clicked a lot more because you're actually seeing it and doing it. And for our OR, because we were at Adventist, we actually got to like do all the IV starts. Do you guys get to do anything or is it just observation?
It's just observation.
Or Kern Medical.
Yeah, only observation.
Bummer. Okay, that sucks for you guys, but you don't have paperwork. We had to do a care plan. So, I mean, I guess win some, lose some. But yeah, that's where we really got to do our IVs because all the patients need IVs before they go in. And so we were doing IVs. And then do you guys get to scrub in though and like watch the surgery?
Yes.
Okay, that's cool. That I felt like that was like pretty fun. Okay, so for the consent, so like one of the questions in that book that I told you about that I was like, oh, this was a really similar question. It was something like, you know, you're ensuring, like, what is your job as the nurse as far as consent goes? Okay, so you make sure that the patient signs the consent and that they like understand what they're signing, but you're not explaining the procedure. You're not explaining the risks and benefits. Like that's the provider's job. So if you walk in and the patient's like, I still don't know if I should get this. Like, can you explain to me the risks and benefits again? Then you're like, oh, hold on. Then you go get the provider. Okay. So that's not your job because the provider needs to make sure that they really understand everything before they go back and do surgery. And so you make sure when you go in, you say, hey, does everything make sense? Do you understand everything? And if they say no, then that's when you can go get the provider to come back and explain it to them. So make sure you know like your job in getting consent versus like what the physician's job is. So surgical checklist.
It's crazy to me that they'll wait until pre-op to finish answering questions because they've booked OR. If the patient changes anything last minute, there's wasted time in the OR. Like all that should be done well before they're at pre-op.
Right. And I mean, I think a lot of it's explained. I think a lot of it is just the patient getting like last minute jitters and like, you know, like, and I think it's different. Like in the doctor's office when he's explaining risks and benefits, and then all of a sudden, like, you have your IV hooked up, you're sitting there and like he's going over it again, then you're like, wait a second, like, you know. So I think it's just the nerves really for a lot of it. So for the surgical checklist, you're just making sure that, like, do they have their, like, because we don't want them wearing jewelry, glasses, dentures, like we want to make sure that like we don't have any of those things on. And then teaching. So you still are doing post-op teaching, but you want to make sure that you're really hitting hard that pre-op teaching, because after post-op, a lot of times the patient's fatigue, like especially if it's like a go home, like in and out procedure, outpatient, then that patient isn't really paying attention afterwards, right? Like they're still kind of on, like, you know, like loopy from drugs, they're exhausted, they're in pain, so they're not going to be taking much in. So really your pre-op teaching is where they're going to get everything. And then post-op, you're still doing post-op teaching, but a lot of times you're doing post-op with the family member or whoever's taking them home. So that way another person hears what you're saying. And then you're sending them home with a bunch of like documents, so that way they can read it in case they forget anything. And then you're prepping them for procedures. So we're doing, so possible bowel prep, like if that, you know, depending on what you're doing, antibiotic for prophylaxis, chlora prep wash, which is to decrease infection and sepsis, and then SCDs. Oh, and then these are some things you could be teaching, like catheter, incentive spirometer, recovery meds, drains, etc. Okay, so intraoperative. So she said to know this, but I don't feel like it was on the test, but the scrub nurse or tech is part of the sterile field. The circulating nurse is not, okay? So the scrub nurse and tech, they are not moving outside the room, but the circulating nurse, it's nice because if they're like, hey, we actually need this, and there's none in the room, she can go out and get it. She is charting, she can go grab documents. So she is out of the field. Yes, Thoraya.
I have a question. So when we go to OR, are we gonna like wash our hands and be part of this sterile field, or are we gonna be with the circulating nurse? That's my question.
So you're not in the sterile field, you're just with the circulating nurse. So you'll wear a mask, and like, so they'll dress you down in like all the surgery stuff. So you have to wear, at least at Adventist, we had to wear their surgical scrubs. So we come in our scrubs and then we change into their scrubs and like put our scrubs in a locker. And then you put on the booties and the hat, and you just like wear that all day. And then when you go into the room, you put on a mask. I don't think you put on gloves. And you just get to like sit and observe. And they might, like the surgeons that I observed, they just like asked me questions, and they were really cool to be like, if you have questions, ask me. So like that was kind of cool to like watch and like ask questions. But I don't know, like, well, you'll be at KM, you said, right?
Yes.
So that actually might be better because KM's a teaching hospital. And so I think that they would probably be more open to even like talking to you and asking questions, and there'll probably be med students in there, which means that the surgeon will probably be explaining and talking a lot more than like our surgeons were. So you'll probably learn like a lot more. So that's really cool.
Be ready to hold a heart.
You're right.
No. Maybe you need to hold some bowel. They'll be like, hold this, and you'll be like, I'm ready. Scrubbed in.
We did get to see, there was a patient that came in for like cardiac arrest or something. So we did get to see like through the window, like we couldn't go all in the room, but they did like emergency heart surgery. So it was kind of see because they had like the ribs cracked open and everything. And we couldn't see super close up because like we were just looking through a window, but we could kind of see what was going on. So that was kind of cool. Okay. So definitely this, there was a question that I think there was like probably two. And one of them was so close in the book. I was like, oh my gosh, this was almost like, I felt like identical. Let me read it to you guys. Like I said, I would read through those like little chapters at the end. So it says, a nurse is assisting an anesthesiologist who's delivering nitrous oxide by face mask to a client during the induction of anesthesia. Which of the following is a priority nurse action? So also when you see questions like this, for me, sometimes I stress out when I'm like, wait, nitrous oxide, like I kind of know what that means, but like I said, I didn't come from healthcare, so I don't know all the words. But make sure you're like, does that matter? Like, no, it doesn't matter really. Okay. So anesthesia, what does anesthesia do? It slows your heart rate. It's like, you know, respiratory depression. So what are we looking for as a priority nursing action? So it's A, assess oxygen saturation, B, measure blood pressure, C, palpate pulse rate, or D, check temperature. What do you guys think?
A and B.
A. So it's not select all but apply.
Oh, okay. I thought it was selection. So then A.
So A, yeah. So our big thing is position and safety, okay, airway, okay? So especially for general anesthesia, because we're giving them those sedation drugs that are lowering like everything, right? Blood pressure, heart rate. So like blood pressure would be important too, but it's not like all of these are important. Like we need to make sure like what's their blood pressure looking like? What's their pulse rate? Like what's their temperature? All of those things are on like this list in one way or another, right? But airway is most important because if they're not breathing, of course, their blood pressure is not going to be good. Their pulse rate is not going to be good. And their temperature, who cares at that point, right? So make sure that like, you know what priority is. So it's always like ABC, or I think Martin now has said CAB. But we're always like airway is going to be number one. Like they have to be able to breathe. Okay. And then IV fluids, like are they getting their fluids? Thermoregulation, are they getting too hot, too cold? And so there was another question on here that was, it was kind of similar. It said a nurse is caring for a client who develops malignant hypothermia, but the question wasn't about a malignant hyperthermia, but it was about a patient whose like temperature has changed. Like we had one like that. And so like, how are you gonna like help the patient? Like if they're too hot, like we're gonna put a cooling blanket on them. We're gonna put IVs in them because IVs are gonna keep the patient cool because an IV is room temperature, which is much cooler than our bodies at 98.6, right? So we're gonna infuse them with cool saline. Versus if the patient seems like they're getting cold, we're going to put warming blankets on them. You know, we're going to see like, why is their temperature dropping? So that's all of our job as a nurse in the OR.
Got that question from the ATI book?
Yeah, say that again.
You got that question from the ATI book?
Mm-hmm.
Okay.
Yeah. So if you look, yeah, so those last couple of chapters are on like anesthesia and peri-op and post-op, and I was reading through it before I came in here and looking at the questions, and a lot of the questions, like they weren't word for word, but they were very similar to questions I saw on the test. And so I do feel like Professor Martin pulls similar questions from which, and maybe they're just from ATI, because you know it's the ATI program, but then kind of changes them up, right? So they're not the exact same, but they're like similar ideas where it's like, okay, if you can kind of understand like the reasoning behind these questions, then you'll understand the questions that she is putting on there. So I would definitely look at those chapters for that one.
What chapter was the one that you just explained, or what
I just read it? I think it was the anesthesia. It was.
Is that the 650 or
so it starts on page 653.
53. Okay.
Mm-hmm. So if
Thank
you look
you.
at 653 all the way, yeah, all the way to
94.
Yeah, all the way to like 671 or 672 or something, and you'll be good. Like pretty much to the end. And I mean, I feel like I said, just scanning like that information is like it's like just the perfect, you know, summary from the book. So I thought it was really, because sometimes I'm like, oh, this is kind of off from what we're learning, but sometimes like, oh my gosh, this is like exactly what they're talking about. Okay, so types of surgery. I don't remember if they went into this in detail. I'm trying to remember. I don't think so, but I mean, it's pretty basic. So general affects the whole body, so it's systemic. Regional, the patient is awake, so like an epidural when a woman gets that in pregnancy. So like lower half is like numb, like pain relief, but she's awake, talking, like very like totally alert. They didn't really go over combined at all. Like she just skipped over that. Did Martin talk about that today? Did she go into detail about that one?
We don't have that on our slide.
Okay.
Our slide is general, regional, monitoring,
local,
anesthesia care, and then local.
Okay.
She didn't mention it, but my daughter had a combined when she had foot surgery. They put her under general, but then also did a nerve block at the back of her leg.
Oh, interesting.
Is it because she'll wake up from general sooner and the nerve block could last longer?
I'm not sure. She was 10 when she had surgery, and the nerve block lasted like a good day.
Oh,
she was like really
what it is
the next day.
That's the point of a nerve block, though.
Yeah, but I just don't know why they did both specifically for her.
The nerve block just blocks the pain. Sedation is something totally different. Nerve block and that's why I was laughing, because the epidural and the nerve block, the epidural, I mean, we keep that so that we're awake for our babies and whatnot, but the nerve block, they'll do that for knees and shoulders. A lot of those, like knees, shoulders, legs, those kinds of things. And it's something that they typically don't have pain for about 24 hours.
Okay. That's
And
cool.
then it hits. Then it hits.
Mhm.
But one of the things I wanted to share is like an anesthesiologist. I was listening to one of his lectures. I went to this one, years ago, and he said there was only 3 things you needed to know to be an anesthesiologist. And he said airway, airway, airway. So that's like something like to focus on. That was like the answer. She's like, what's the most important thing an anesthesiologist will look at during surgery? And it's airway.
Okay, awesome. Yeah. I know that for sure, like that's their most, and like obviously in surgery, it's not just you checking on the patient, right? But it is part of your job that we're making sure, the patient's airway is clear, IV fluids, thermoregulation, safety positioning. So obviously there's a lot of people in there, helping the patient, but along with the anesthesiologist, like they're keeping an eye on vitals, but we're kind of keeping that in the back of our heads too, right? Just making sure patient's okay.
The only other thing is that Sandgill completely had types of surgery and anesthesia completely highlighted. Like that.
Oh, did she?
She had that whole section highlighted.
So did you find that the test went along with what she had highlighted on the slides or no?
I don't know. I overthought studying, so I don't know. I was watching like all kinds of YouTube videos. Like I went way too in depth with my studying compared to like
me.
I don't know, I feel like it wasn't super cohesive with her slides.
Yeah, like I was like, oh, like the cells are swelling and now they're decreasing, and like I was watching YouTube videos on them, and I think I just overthought it like way too much.
Did they ask about that at all? Like prenation, any of that?
Nope.
No.
Like at all?
Nothing
They didn't
with
ask
isotonic, hypotonic, hypertonic, nothing like.
I feel like the only time they touched on it was that last question, which was the
which was thrown out.
Which was thrown out, but it was asking, it presented like a case patient, and it's like you would administer D5W, and then like 2 options down, it was like you would administer like normal
saline.
Okay.
I had to determine which one you would do and which one
But
would
it asked which ones were contraindicated, indicated, and which ones weren't necessary. And then she threw it out because she said it was a next generation inflex, and it was almost like a practice question.
Oh, interesting.
Well, I think she threw it out because a lot of people got it wrong. Because we've had since first semester, they would give us NGN questions like that. We would have like 1 or 2 on the exams. And they were common for us to have them. So they started throwing them in for farm and everything. So they're gonna keep giving them to us. But I think the reason she threw it out was because a lot of people missed it because of the wording. And then I don't know, the labs threw me off, but that was just my personal reasons because I was being done with my memory. But
yeah, and see for ours, I know for sure, like we had like 1 or 2 questions on like hypertonic versus hypo, which is why I was like, make sure you know this. So obviously they totally, and that question you're talking about was not on ours.
But I feel like what you told us was more accurate than what we got in lecture with San Gil, because I really do think that she kind of just took her exam straight for straight so that we would be tested on the same thing. But because we didn't get the same lecture that Martin was giving, there was probably a couple of things that she didn't talk to us about that were on the exam. Which is why I think she ended up throwing some out.
Okay.
Because even the other one that she threw out was a math one, and even the math one, the one that everybody, I don't even remember what it was, but it was like something that I was like, well, I did the whole worksheet and nothing like this was on there.
Oh, weird. Okay. And I'll send you guys like some math problems with like explanations too. Like I said, I would do like that ATI IV calculation, like that takes you through like 25 or something questions with rationales that I think is helpful. But I can send you guys some too with like, the answers. So that way, like, and then if anyone like wants specific help with that, I could do like a med math Zoom sometime or something. Okay, so for post-op, so this is where that question that we had was about like debridement or whatever. So make sure that you know that you're assessing and monitoring. So that means that you're doing vital signs often. I think in post-op, post-op they're hooked up where like to the heart rate monitor and everything. So it's gonna beep if it suddenly like goes down or goes high. But they're taking like vital signs like pretty often.
Every 15.
Yeah, I think it is every 15. Just to make sure that like the patient, doesn't suddenly go hypotensive or anything. And then post-op teaching, like I said, a lot of times it's gonna be with family members if the patient's like really out of it. If they're not staying like, overnight the next day or whatever. So right here, so wound management, not debridement, but we're making sure that their wound's okay, that they don't have any like dehiscence where it's like, coming out, like the inner organs are coming out. We're making sure that, their pain management is good, whether that's with, usually right after surgery, it's going to be with drugs, right? We were kind of doing round the clock drugs until they're kind of getting over that acute pain. And oh yeah, and then when it talks about PCA pumps, that's going to help them, it's going to manage their pain really well. And so that's going to help them ambulate faster, which prevents them from having like pulmonary complications. So they need to be fully awake and alert so we can make sure that like they're they don't have any like altered mental status afterwards, right? We're making sure that like we can talk to them, ask questions, they know who they are, that kind of thing. And then make sure that they pee before going home. So like, are they urinating correctly? Because anesthesia can sometimes cause, like urinary retention. It slows everything down, right? It slows your bowels down, slows like genital urinary, all of that. So just make sure like post-op, kind of like what you could do. So even though this says like assessing and monitoring support physiological functions, like I said, don't just have a list, because on the test, they will probably say, they'll put like specifics, like what would be a nurse's function in post-op phase? Like, giving the patient gabapentin or giving the patient, like assisting the patient to like the restroom, or I don't know, like I'm just coming up with random stuff, but like it's going to be specific. So just make sure you really like, you're not memorizing, you really understand like what these words mean. Okay. And that's where I think it's going to help if you like, so at this point, so like I'm saying, like, I wouldn't read the book, but like if there was something that I'm like, well, what exactly does this mean? Support physiological function. Like that's where I'm going to go to the book and be like, okay, where does it say that? What are examples that it's giving? Or that, that purple med surg book that I've been showing you guys, where does it say that? What examples is it giving? So that I really understand what that means. Okay, so, and then, so this is still, so you're doing vital signs, you're doing lung sounds, because patients after surgery are likely to develop pneumonia or pleural effusion if they're not moving, right? If they're not using that incentive spirometer. Bowel sounds, because they have risk for ileus, right? So their bowels can just like get kind of frozen because everything's slowing down, and you don't want them to get like totally blocked up and have paralytic ileus, okay? Surgical incision for infection, bleeding. So what are signs of infection that you're looking for? So you're looking like, is it like, so out of surgery, it's going to be a little red, right? Because it's irritated, but is it like super red? Is it like warm to the touch? Is it like, they're going to have some pain after surgery, but like, are they like, oh my gosh, my side is burning, like where they're, especially even after you're giving them pain meds, right? So like, make sure you're looking for, what those signs are of infection in a wound. Drains for, so this could be San Gil if she's using the same thing, but I know she did mention something like, I think it was the JP drain. It might have been the, I can't remember what this one is called. Hold on, it's in that page I showed you to look at. But there's that other drain too. Just make sure you kind of look at them and see like, what are they doing? What is it? Like you're looking for fluid. What color is the fluid? For the JP drain, you have to squish it first so that it has that suction, okay?
Yeah, she talked about that just to make sure that we know that it has to go flat and then you put the thing in. So I remember she mentioned that, so that could be on there.
Okay, so Penrose drain. So Penrose drain is this one right here. And so that one is actually like inside the patient, like, and it's sutured around it. And then I actually, like when I was in med surge last semester. One of our patients needed one out. We can't pull them out, but our CTA told us all that she was doing it so we could come watch. And so they just like kind of loosen the stitch around it, and it was really gross, but they just like pull it right out and then just kind of pack, because then it's going to leak a little fluid, and they just kind of pack it, and then it will heal on its own. Like they don't have to come stitch it unless it's not closing. But that one is like inside where the stitching is. And then I'm not sure how this one attaches so much.
They're the same. It's
same
just
idea.
Concept, yeah. And it's like removing an NG tube, same kind of concept. So expect some flinging at the end if you're not careful, if you ever pull them out.
Yeah. And I know that I don't think we're allowed to as nursing students. I think it has to be the CTA. But yeah, it was interesting to watch. So just make sure I would go through these 2 drains that are on here. I mean, just basic, you don't have to go any like deep in it, but just make sure you would know which one is which. And just like, this one you have to squish first to get that suction. Just kind of how they work a little bit, because there was a question on it, and I don't remember what the question was, but I know there was a question on drains. And so with that also, you're looking for like the drain wound. So you're making sure that like it's suctioning, because if it's supposed to suction and nothing's coming out, well, why? Is there a blockage somewhere? Is the drain not working correctly? So make sure that like if fluid's supposed to be coming out, what is the fluid, like, is it coming out? And then how much? We're measuring that. What consistency is it? Is it like really thick and like kind of putrid, or is it like thin and serosanguinous? Like, what are we looking for? Okay.
I just looked it up. The difference between the two, they pretty much
Mhm.
function the same, except for the JP has that suction factor. The
Okay.
pancreas has to stay to gravity.
Okay.
So it doesn't have suction, but it goes to gravity.
Okay. I think that's all you'd probably have to know for those. I think you'd be good. Talked about that. And then the neurovascular will be on the next page. Okay. So make sure you know your 6 Ps. This is for sure. Well, for sure. This was for us, a quiz question. And I assume it will also be a test question. So make sure you know like these words and what they mean. Okay. So really the only words maybe you wouldn't know is paresthesis. So that's the numbing, tingling, and then the poikilothermia, which is coolness. And then you're comparing the injured part with its symmetric counterpart. So I feel like there was a question that was like, your patient's leg, like you get a new patient and their leg looks swollen and, pale. What's the first thing you do? Like, do you call the doctor? Do you list all these things? The first thing you do is you're going to compare it with the other side, right? Because maybe that person just has like kind of fluffy legs and pale skin, right? Like maybe like some people are fluffy. So maybe you think it's swelling and it's not. So you're always going to compare it first with the other side and see like, oh, this is just what this person looks like. Or it could be like, okay, yeah, this is like this is a very thin person and they're, like darker skinned, and this leg is very pale and very puffy, whatever, right? So you're always going to look at the other side first. Okay. And then cap refill, which you guys should definitely know about by now, and then edema. Okay, so for post-op, this is all part of post-op. So incentive spirometer, you guys should know about that, teaching them how to use it. And then I don't think this was on the test, but Professor Martin just said acute pain is the top priority for a care plan if the patient just came from surgery. So normally we say pain is not a good second semester like plan of care problem. But if your patient just came from surgery, then acute pain is top, because if they're in a lot of pain, they're not going to be willing to walk around. They're just going to lay in bed. And then if they're laying in bed, then they're at risk for pneumonia. And if they get pneumonia, they're at risk for sepsis, right? So it just kind of goes down the line of worse and worse. So we do want to make sure we get on top of that acute pain, so that way they're more willing to be compliant with the other things we're asking them to do. Know some meds that you would give them. So antiemetics. I don't think she asked specifics on the test. I know that like Professor Sangil was hinting at that, but I think it's just because she has such a strong background in pharm that she's always asking you guys pharm questions. It could have been, but I don't remember it being on the test. But we're giving PPIs, for GERD because it protects the stomach from heartburn reflux, from getting stomach ulcers, like over the stress of everything. Patients have constipation related to pain meds and immobility, heparin for VT prophylaxis. So this should all be pretty familiar. And then antibiotics. And I don't think, like I said, I don't think that they ask specifics, like, you know, as far as like antibiotics or anything. So just know like the skip that you're gonna give prophylactic antibiotic within an hour, and you're ending it within 24 hours. I think it's 24 hours after surgery. I think that's what, is that the same thing that like Professor Sangil gave you guys? Did it say 24?
We don't have this. I don't know.
It was, we don't have this slide, but she did tell us, and it was
It's 24 hours.
yeah.
Okay. She did, because I remember she said that like she was gonna post it or something, so you guys had that extra thing that she added. So something like this was on the test. I think it was just, like, I think it was select all that apply. So like, what are you gonna do for, you know, surgery patient? So it's the antibiotic within an hour pre-op. I wouldn't worry. Oh, maybe that beta blocker was there. I can't remember.
Ours has, it just has 4. It has antibiotic received 1 hour prior to incision, prophylactic antibiotic selection for surgical patients, prophylactic antibiotics discontinued within 24 hours after surgery for hip and knee, or 48 for cabbage and valve, and then
Okay.
ETE 24 hours prior and 24 hours after surgery.
Okay.
Yeah. It was just posted in like the little chat.
Okay. Okay. So for Sangil's class, I would grab that. For Martin's, I know she specifically said like no shaving. So if there was a question in the ATI book that said something like, it had a very similar question that I remember being like kind of similar on the test, where it was like, what would you do to prepare the patient for surgery? And it said like shave the affected area. Well, we're not going to shave the affected area because then you're putting the patient at risk for like razor burns and razor cuts, which is going to lead to infection. And then we're like, they're going to have a urinary catheter, like a Foley cath in surgery, but we're going to remove that as soon as possible after surgery. So like 2 days at the latest, because we're trying to prevent any sort of infections that are going to be related to having a urinary catheter. For faces, you don't have to memorize this, just know who you would use it for. So you're going to use it for like children or people like that aren't able to like tell you how they're feeling, right? So we're going to use that. And then for flack pain scale, again, don't memorize this at all. This is mostly used for like babies, but can also be used for like patients that again have like, you know, kind of the mental status of like an infant or a child, right? So maybe like they're non-verbal, and so we're going to use this. So you don't have to memorize this. I would just know that the lower the number is, the lower amount of pain they're in. The higher the number, the higher amount of pain they're in. Okay, because that's how they're rating these. Like these are all zeros, these are all ones, these are all twos, and so if they're getting all twos, then they're going to be like at a 10. Okay, versus like a 0 would be like they're totally happy. Okay, definitely know what all of these are, which you learned in first. Okay, so what triggers the pain? What is the quality of pain? The region or like the area is it radiating? Severity and timing. Okay, so for your pain meds, I put a few down here, just like side effects of like different ones. I think I just had the first 2. So acetaminophen, I would know that like in general, you're not like, that's really safe. Like we don't have a lot of side effects from that. You're just keeping an eye on your like maximum daily dose. Okay. And then you can mix acetaminophen and NSAIDs to like, you know, ibuprofen, Tylenol every, what is like 4 hours or something to really stay on top of that pain. NSAIDs are hard on the stomach. And so with NSAIDs, we do have to like kind of look for any sort of like GI bleeds, because it can cause, you know, stomach ulcers and things. Opioids, there's a decent amount of side effects going with that. They're great for pain control. It was my favorite pain control when I've been in the hospital, but there are definitely lots of side effects. And then I didn't look up these 2. So you would just want to look up, if I get time, I'll throw in some slides. But so this one, Martin specifically said gabapentin is used for pain control. So just antidepressants in general, like what are some of their side effects from that? And then anticonvulsants. So she said review actions and side effects. I don't remember if actions was on there, but I do know there were side effects on there. And I don't think that this was this on San Gil's?
No.
It doesn't
Okay.
look just like that, but it looks similar to that.
We have
Okay.
the slide. Yeah, we just have NSAIDs, opioids, and acetaminophen. So, yeah,
Okay.
we don't have the other two.
Okay, and I don't.
Approach and non-pharmaceuticals.
Okay, I don't remember these two being on the test, but I mean it could be. For pain meds, I know Martin said just focus on IV. So that's because that's what you guys are focusing on this semester. So like I said, so here are the NSAIDs, like the big one. So it's a bleeding risk, because it's like it can, thin the blood a little bit, and then kidney problems, hypertension or stroke, and then stomach upset or ulcers. Okay, so we're looking for that's what we're kind of looking for with NSAIDs. And then with opioids, this is what you're looking for. And there's a question in that purple book that was select all that apply. Like, what would you be looking for opioids? And so I threw in a couple other things I didn't have in here that you'd also be looking for. And I wouldn't worry about this delirium or somnolence, even the pruritus, even though you're definitely going to see that probably, but the other things you're going to look at for opioid medications. For PCA, I'm going to say no, but then I'll say that and then watch it probably won't be on the test. But there was a select all that apply question for us on like, it was either the advantage, I think it was the advantages, might have been disadvantages, but I think it was the advantages. So like I've mentioned this a few times. So the patient has a higher satisfaction because they can control it and give themselves the medication when they need it. So a lot of times, like I've never had a morphine pump, but when I've been in the hospital and I have needed pain medication, and so I call my nurse and she's like, okay, I'll get it to you in a second, but I'm lowest on the list, right? Which makes sense because like, yeah, I'm in pain and that sucks for me. But if there's patients that need their like diabetes medication or, that they just came back from surgery or whatever, like those patients are higher on the list. So then sometimes you're waiting an hour, 2 hours to get pain meds. And by then you're like, oh my gosh, I'm dying, right? So PCA pump is great because the nurse doesn't have to worry about like running in there and getting meds. And the patient, as soon as they need it, they can just push it and get that, within, a couple of seconds. So it's a lot easier to patient satisfaction, which like we talked about, then they can ambulate earlier, which then decreases pulmonary complications, which then decreases hospital stays. So these are all related to patient satisfaction with like staying on top of that pain. So the disadvantages, when it says improper patient selection, that means like we have to be careful who we're choosing. So we can't have a patient that has disabilities and doesn't understand how to use it, or that is confused, maybe has delirium or dementia, or just doesn't understand it. So just barely last week when I was at MedSurg, one of my patients had a PCA pump and he kept complaining that his pain was 10 out of 10. And we're like, well, did you press it? And he's like, no. And he wouldn't push it because he was like worried about giving himself too much. And we kept trying to explain like, that's not possible. Like we programmed the pump that it won't give you too much, but he was just afraid of using it. So he was in pain. So at that point, it probably doesn't make sense for him to be on this morphine pump. It probably makes sense to just take him off it and give him some oral meds or IV meds or whatever, because he's not using it the way he should. And so it's not really it's not giving him any sort of, positive like things. PCA by proxy, so nobody else can push it. So, brother can't push it or mom or the nurse. And so we have to make sure they're pushing it. It's possible that there's pump problems, machines aren't perfect. Maybe they get unplugged or it just breaks or something, and then human error because there is somebody programming it in there. But it is, down here talks about it. It is 2 RNs. And I know this is highlighted and Sangil said about it, but it wasn't on the test when we took it. It might be, but it's important to know this. Let's see. So I would just know it's, I feel like there was a question about like disadvantage or something, and it was like the patient could overdose. Like that's not really possible on these machines because the prescriber is choosing the dose and then the interval and the lockout interval. So he's going to choose, or she is going to choose, like, do not give more than, like, let's say like 3 grams a day or whatever. And so even if the patient is continually pushing it, it's not going to give more than what the prescriber has said per day. So it's not, you're not going to get too high of a dose, okay, and have like toxicity issues. And then it's going to, if you push it and it's like every 10 minutes you can get more. If you push it and 2 minutes later push it again, nothing's going to happen. So that's what that like interval, demand interval is. So like it, you know, will only give you at every 10 minutes, even if you push it in between the 10 minutes. I feel like this is all pretty self-explanatory. You're doing it based on what is ordered. You're having another RN check it. These are things you're, you know, always checking anyway. And then we're monitoring for oversedation. So make sure you know what you're looking for with that. So you're looking for a respiratory rate, like, was it less than 10 or 12, like whatever they're looking for with sedation. And then you're looking for like really low heart rate. Is the patient responsive when you like talk to them? Like, can they talk back? Like those kind of things. And then, oh, here we go. Sedation rating tool. Was this on San Gil's?
No.
No.
Okay, I don't remember this being tested on at all for Martin. But I would just know like that we are just double checking like sedation, right? So we're checking their SpO2, like what is their, you know, percentage and their respiratory rate, and like, are they awake and alert? Are they kind of slightly drowsy? Okay, well, morphine makes you drowsy. Are they frequently drowsy? Like they can't even stay awake? Well, then we're going to decrease the dose. If they're not responding, we're going to stop and we're going to probably order Narcan and call the provider. And that's it. And then I will send the, oh, sorry, there's 33 chats. Were you guys just chatting?
Mostly.
Okay, sorry. Sometimes I like start talking and then I like don't realize you guys were like asking questions. I really try to pay attention to that.
We kind of answered each other most of the time, I feel like.
Okay, good. Just know if I'm not ignoring you, and you can always interrupt me and say, wait, I have a question. Like, I'm not offended, just because I can't always see if someone's like obviously raising their hand or something. Just be like, I have a question, and interrupt me. It's like, it's totally fine. Okay, any other questions on anything?
Yes, I have a question, Lauren. So how would you say you'd study for these? I know you told us different options, but how would you personally study? You just based off the lecture? Do you go to ATI, MedSurg book, Google, Quizlet? Which one do you prioritize?
So I definitely don't do ATI because I don't feel like they use off ATI. I feel like ATI is good for studying for NCLEX. So
No,
what
mean
I
the book
did,
questions, what you
oh,
said.
the book. Yes. So that's what I did. So sorry. So the way that I did it is I went through, and it's still how I study now, is I would go through and I would look at a slide and be like, okay, it says age-related changes. What does that mean? You know, like, so I would look in the book under age-related changes and kind of read about it. And if there's anything that I'm like, oh, that's interesting, that's a, you know, a good fact or whatever, I would write it in. I would like look up pictures in Google and add it to the slide. So, you know, sometimes a lot of my slides have like extra pictures in there that I found. That's so first semester, that's not how I studied. And so all that stuff that was me prepping for you guys. And then I was like, wow, this is a great way to study. And so then I started doing it for me for second semester. So I started adding things from like Google. I would like watch YouTube videos that sometimes I send you guys if I find good ones. So anything like that, because I'm a visual person. So seeing that visual helps me. And then I definitely do practice questions out of this book because I found that Martin, a lot of the questions are similar to ones I find in here. And then sometimes I feel like she doesn't use the questions. So some of the questions from F.A. Davis, you know how if you go to F.A. Davis and you can go to like the extra resources, you know what I'm talking about, how it has those questions. Some of those are really useful too. So I never have read the book front to back. Like, I think that's a waste of time. But if there's something that you're really confused about, then yeah, use the book as like a resource, or Google or YouTube. And then add pictures from the book. So you can, like, I go online to the book and I screenshot a section or a chart that I think is good and pull it into my slides. So anything like that, that's how I do it. And then another thing, when it says objectives, like a lot of them at the top, this one doesn't, but a lot of them at the top will say objectives. Maybe the peri-op. Yeah, so the peri-op does. So it says discuss the role and responsibilities of the peri-op nurse, peri-op nursing, intraoperative nursing, post-operative, identify members of the surgical team, like whatever. If I can like answer those and like discuss those confidently, then I feel like I'm good. Does that make sense?
Yeah. Thank you so much, Lauren.
Mm-hmm.
Also, shout out to that video you posted and for sharing about the pH and the CO2
Oh, good.
Like, nailed it. Thank
That's
you.
good, right?
I nailed my ABGs only because of that.
Yep.
Yeah. Yeah. Martin showed us that, and I was like, oh, genius. Because otherwise I was on my own. Like, I was like, I don't get this at all. But that made it so much easier. Any other
Lauren,
questions?
Yeah, would you be able to send us the PowerPoint slides? This is my first time attending your tutor session.
Yeah. Are you on the email list, Alma?
Yeah.
Okay. Yeah. So I will send them out. I'll do it tonight. And so you guys will have copies of what I have. And then I try to send like a little quiz out. And so I will do that, not tonight, but I will do that later this week.
Thank you.
Any other questions?
Do you have a plan for Saturday yet?
No. So did you guys get my email I sent out about that to vote on that? So I'm just waiting because last I checked, only 19 people voted, which, I mean, if only 19 people care, that's fine. But I'm going to close it tomorrow night. So I'm just going to wait and see. I just wanted to remind people. And so I'm going to wait and see, if more people respond. Right now, it's looking like, I think it was 3 o'clock. Looks like the top, what people want. And so definitely changing it, because like, don't change it was like barely anyone voted for that. So I apologize if you're one of the people that said don't change it. But I know people are recording it, and I think Lewis is recording and putting on YouTube, or someone is. So you're welcome to record anytime or get off YouTube.
So I have an odd question. I have SimLab coming up. Is there any way to prepare for SimLab?
Not well, so they'll give you stuff to do ahead of time, right? Didn't they give you like something like paper to do ahead of time?
They sent me a scenario of like a pre-op or post-op stuff with some labs and whatnot, and they said to go ahead and do a care plan on it.
You had to do a care plan on that?
It was something like that.
Before you come?
That's what it was saying, and I was trying to understand it. That's why I wanted to kind of get clarification on what you did.
I don't think it says care plan, but it definitely says we have 10 concept maps to do before we go in that we have to hand in the day of.
10?
There's
one on, I just looked at all of it earlier because mine is coming up.
This one says use clinical paperwork expected for your clinical documents to prepare for your simulation event. The paper must be handwritten and complete on arrival at simulation. Incomplete clinical preparation may result in clinical absence. There is no makeup for simulated events.
Okay, let me look. So I had to do a write-up afterwards. I don't remember if I had to do a...
So you have to do... looked at it. Is this San Gil or is this Nancy?
This is Nancy.
Oh, it is? Oh, I got the one from Nancy.
Well, I got the one from Nancy also, but if you look, because Sangil sent out a message saying she posted the SimLab instructions.
Right.
So I just had it up earlier too. But yeah, there's like a bunch of concept maps we have to have done before, unless I'm reading it wrong, but where'd it go? Under SimLab 1.
The email I got was just one concept map for our patho.
Yeah, so it says upon completion, you will need to submit 1-page reflection related to your experience. This 1-page reflection is due 1 week after completing your simulation.
If you click on the simulation 1 under assignments, it says you must bring your completed paperwork, blah, 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 blah.
Yeah.
Then it says post-op complications. Please complete a concept map for post-op complications, including your signs and symptoms, rhythm, risk factors, medications, diagnostic, nursing interventions, pathophysiology, and potential complications. So that's all going in just a one concept.
That's one concept map. Yeah.
Okay.
Yeah, that's one concept map. You have to do 10 of those?
No, it's at the
no,
bottom of the
just one.
paperwork. It says daily plan of care. You should have ideas to share with the top problems. There will be no evaluation, a patho map based on your review of daily labs, and a medication sheet is what you need.
I just read it wrong.
Okay. Okay. Yeah. So I think now I do remember that. Oh yeah, because we had to handwrite it, which was annoying because we couldn't share it with each other. So you could still. We're not recording anymore, right?
No, we're not.
You could still split it up and then just share it with each other.